Hello, my name is Carrie Jennings. I am the Accreditation Manager here at University Medical Center. Today we will be discussing restraints. If you will look under the title Restraints, you will see SPP PC 36. This is referring to the hospital policy regarding restraints. As you practice here at University Medical Center, you can refer to this policy at any time for any questions, references. There's also algorithms at the end of the policy to be able to reference as needed. These are the objectives that we will be discussing today. We're going to identify the statement of purpose here in reference to the restraint policy for University Medical Center. I'm also going to describe which practice does not apply to restraints. Also identify measures taken to protect patient rights. Restraints is a huge patient rights for Medicare and Medicaid services. They monitor this very closely. And so a patient in restraints is all charting and documentation when and how is monitored very closely. I'm going to go over the restraint definitions and categories, also describe patient monitoring and periodic assessment of patient restraints. Also, I'm going to go over when side rails are considered restraints and when they are not a restraint. We're going to go over considerations for restraints, alternatives that you can go over with the patient. We're going to go over key safety issues related to restraint use. Also, the importance of patient and family education. During your nursing orientation, you will demonstrate proper use and removal of a restraint and be checked off on this at a later time. Identify prolonged use of restraints we will discuss here during the PowerPoint, and also explain the nursing care plan specific to restraints. Our statement of purpose: to use restraints or seclusion only when essential to protect patients from harming themselves or others, and when all other interventions have been unsuccessful. Our goal here at UMC is to protect the patient's health and safety and preserve the patient's dignity, rights, and well-being. This is simply a statement for our organization as a whole. We do not use restraints for our convenience. This is to keep the patient safe. These are the only times that we will be using restraints, and we will have to document all of these. So restraints is something that's monitored very closely, and this is our statement of use. And we always want to preserve the patient's dignity and rights as a person, and also for their family and loved ones. To go over really quickly just the non-applicable to restraint policy. There were some questions when we were going over the restraints policy, is that there's certain practices that limit the mobility or temporary immobilization of a limb or of the patient. And if it is related to any medical, diagnostic, or surgical procedures or post-procedure, this is not considered a restraint. And what this means is that the physician does not have to place a restraint order, and also you do not have to do the certain assessments that go along with restraints. So, for example, a dialysis patient, if you strap down one of their arms while you're accessing their dialysis catheter, that is not considered a restraint. They still have the ability to use their other arms. They could get out of it. This is to keep them safe as you're keeping an arm from moving. Same thing as in the OR, they strap down a limb that's having surgery on. Those are the type of things that are not considered a restraint, do not have to have an order. Also, forensic or correctional restrictions used by the law enforcement for security reasons do not require a restraint order or the full assessment that goes along with restraints. And I'll go over here in more detail on the forensic and correctional restraints, what a nurse is responsible for, or when an order is needed versus when it is simply that does not need to be taken care of by the nurse. This will be law enforcement's responsibility, is their forensic restraints. Measures taken to protect the patient's rights. Of course, restraints will always be based on the patient's assessed needs. Every patient that you are about to put a restraint on requires an assessment of the reason why the patient needs restraints. Also, the patient and family member will be informed of the reason for the restraint. And of course, if you ever put yourself in the shoes of if you were the patient, or you walked in and say your grandparent was in restraints, you would want to know the reason why they have your grandparent tied to the bed, especially if you do not understand the medical reasons for this. This can be very alarming, especially to family that just walks in. So very good education really helps the family and also the patient to understand the reasons of why that you're tying a limb down, you're tying their arm, you're tying their leg. The patient and family will always be informed of the behavior that will allow for safe removal of the restraint. As long as the patient does not pull on their IV tubing due to they really need this for their medicine, whatever, if you will stop pulling on this for the non-violent restraints, then you can remove them. Of course, you always want to do the alternatives least restrictive first. Be sure to discuss this with your patient and families. We've attempted this, we have done this is still not working. Our next step is we're going to restrain them. And the nurse will document patient and family education on the electronic restraint education form. And when you go into the IT part of the charting for Cerner, you will definitely be educated on the restraint education, all the task list, and we'll go over a little bit here in just now we're going to cover some definitions on restraints. First, you have restraints, which is the manual method of restricting a person's freedom of movement or physical activity, any restriction from normal access to his or her own body. These are known as our nonviolent, which used to be called our medical restraints, and also our violent restraints, which was also called our behavioral restraints. This is the definition of the restraints: the physical soft, posy vests that hold them down. You're tied to the frame of the bed. These are known as restraints. There's also the specific seclusion, involuntary confinement in a room or area where the person is physically prevented from leaving. The emergency center is the only place that there is 2 seclusion rooms. These rooms are monitored by video. They are located at the nurse's station. If anyone is in seclusion, they have to be monitored on a regular basis and very strict guidelines on a patient in seclusion. The emergency center is the only place that will be doing seclusion. You also have the chemical form of restraint, which is a drug or medication used as a restriction to manage the patient's behavior or to restrict freedom of movement. Chemical restraints is any drug that is given that does not help the patient function on a daily basis. So if you're giving Ativan to sedate the patient, this is a form of chemical restraint. And then you also have your forensic restraints, which is prisoners in custody of law enforcement or correctional facility and are required to have hard restraints on all 4 extremities. If you'll notice in the parentheses, you have PC 29.2. This is the exact policy that covers the forensic restraints. And I will go in further detail on what the nurse is responsible for forensic restraints here momentarily. Our first category of restraint is the nonviolent, which also I said earlier used to be called our medical restraints. A nonviolent restraint may be necessary in clinically justified situations, such as to ensure a patient who is temporarily or permanently cognitively impaired does not remove essential lines and or tubes. This is your most classic form of restraints. You see a lot of these in the ICUs with intubated patients. If you can't get them sedated just right and they're moving around, or they have the ability to pull their ET tube, are at very high risk, you will see these restraints in use. They are called nonviolent. You will also see these maybe if a patient is trying to pull out an IV line. They may not be cognitively impaired permanently by sedation, but maybe their medical history of neurological issues that prevent them from understanding why they shouldn't do something. Nonviolent restraints to be able to keep things from being removed is appropriate for these type of patients also. Our next category is violent restraints. This is used to limit in emergencies where there's imminent risk of patients harming self or others. A safety demand response. These are the ones, of course, security shall be notified immediately for severely aggressive or self-destructive behavior. In the emergency room, again, you will see them in the seclusion rooms if those are available, if it is truly a violent or self-destructive behavior. And of course, trained nursing staff may restrain if security is not available. Now, during nursing orientation, everyone will be checked off for the placing and removal of restraints. Therefore, you are able at any time to restrain a patient. But however, if these patients are extremely violent, of course, you're always going to have more than one person. Hopefully, you're going to be calling for help to get in here because this patient is coming at you and you're fearful for your life, or they're trying to hurt themselves immediately. And then someone needs to be on the phone dialing security. Of course, in the emergency center, you have the LPD officer down there 24/7. There's always several people to be able to help you, but in a unit, it is a little more isolated. In a code orange, this is what the situation that a code orange could be called. So this is very high risk. This is immediate, and you would put them in here. A violent restraint. Violent examples include severely aggressive, agitated, combative, attempting to hit or kick staff, spitting, biting, using objects as weapons, or etc. So, of course, just remember, in which any physical harm could be done to staff or other patients or to the patient themselves, this meets the definition of a violent restraint. Now we're going to discuss side rails. There's always been a few questions regarding side rails, when a side rail is considered a restraint and when it is not. So let me go over those quickly. Top side rails, just the two top on a hospital bed, is not considered a restraint. However, if you use the full side rails for a patient who is not responding, this is also not considered a restraint. However, if you use full side rails to limit the patient's ability to ambulate, this is considered a restraint. And of course, remember, restraint is all about the intent. If you're intending to keep the person in the bed, that is restraint. And this could even be more dangerous than just having the bottom two. Because of the risk of the patient, if they want to get out of bed, what are they going to do? Of course, they're going to climb over and jump, and then you have the risk of a fall with injury. So full side rails, trying to keep a patient in the bed, is not a good idea, and that is considered a restraint, and you would need an order. Full side rails at a patient's request, however, is not considered a restraint if the patient wants them to remind them that the bed's really narrow, or they don't feel comfortable with the bed being lowered and they still consider themselves that they might fall out, and they've requested it. I would just document it in your nurse's notes, and this would not be considered a restraint. Patients who wander. These can be very difficult patients. These can be very trying patients, especially when you're very busy trying to keep them in the room. Of course, there's several clever prevention techniques that you can always research. We went over some in restraint committee at one point, and it was someone just literally put a tape on the floor and said, you are not allowed to come across the tape. And so the patient would sit there and they never came across. They would come to it, but they would just wander in their room. So it really made them remember that there was a boundary. Also, redirection to the room. And this is really when you would want to consider a sitter for diversion techniques. When they failed, we do have sitters available. And so this would be where you would go to your charge nurse, especially if the patient is high risk and they shouldn't be left alone, they have no family members, to request, they can call the house supervisor to request a sitter for you to kind of help them keep them engaged. Of course, here's your nursing policy 150.2 that speaks to the sitter. Now, falls. A patient history of falls does not equal the patient automatically gets put in restraints. A history of falls without evidence of falling is not a good enough reason. Now, if they've fallen or this is for a medical reason and the physician has ordered it, then that would be different. But just because they have a history of falls does not mean you automatically put them in restraints. So let's discuss restraints and suicide. If the person has been placed in restraints and or seclusion due to concern regarding suicide, the documentation of the observation and assessment can be found under SPP, PC number 15. We also have it where it is electronic, that as long as you order the restraints due to suicide, which is a medical reason so they don't harm themselves, the task list will automatically populate how often you have to do your assessments and your observation. And so this should be fairly simple as long as you complete your task list. But everything that we've done in Cerner for the electronic charting does meet the requirements for the documentation on these patients. A restraint is considered only if needed to improve the patient's well-being. So this means there is not a set for this type of patient, they will always receive a restraint. This is not true. And of course, everyone probably thinks, well, every intubated patient equals they get restraints. This is not true either. If you have a patient that's not going to move, they've had a stroke and they're paralyzed, they're weak on one side, they're not moving, their neuro assessment is not very good, then there is no reason to do restraints. So once again, it is a patient-to-patient basis and you need to do your assessment. Always less restrictive interventions must have been determined to be ineffective always before putting on restraints. This will also be required in your charting documentation. If implemented, the least restrictive manner possible must be documented. And if they can be discontinued, they need to be discontinued as soon as possible. And after a comprehensive assessment of the patient with the conclusion that restraint benefits outweigh the risk of a restraint, then let's go ahead and put the patient in restraint. Of course, here's some alternatives to restraints. Family members present, you can draw the blinds or quiet the room, reorientation or reassurance to a patient, Curlex wrap. Soft mittens are not considered a restraint, and some people have asked in the past, well, why? They can still move their arms. They still have access to their body. They're just not allowed to really scratch maybe with, but they still have that movement. You are not tying them down to anything. Sometimes improved lighting where they can actually see, or medical management for example, the sundowning patient. Bed alarms, of course, and let them get out of bed, get them a Jerry chair. So these are some types of alternatives that you will try or should try before putting the patient in restraints. Initial documentation. These are the biggest things that you will have to document. We've made it very, very simple in the electronic charting. Everything that is required is highlighted in yellow. It will not let you save and close out until these areas have been documented on. The restraint type and location, if there's any secondary restraint. Say you have soft restraints bilateral wrist and you also have a posy vest on. If there's none, then you would put none. If there were any alternatives attempted before putting in the patient in restraints. Behavior requiring restraints, and there's also a comment area where you can actually type, how is the patient acting? What were they doing that made them need the restraint? And then also you have the restraint guideline and acknowledgments that you've explained it, the patient understands it, if this is appropriate, and you will be documenting all of these. Ongoing assessment documentation, this includes, of course, If the patient continues to need it, you'll hit yes. The reason why they still need it. Interventions that need to be attempted or have been attempted to remove the restraints. And then, of course, always confirming that the correct physician in which the order is currently under is the one. And this has been issues in the past when, say, the patient was put in medical restraints or nonviolent restraints down in the emergency center, and they were taken care of by the EC physician. Then they're admitted under Dr. A and go to the MICU. These orders need to be updated to reflect Dr. A is now responsible for the order and signature of the continuation of restraints. And then, of course, the type of restraints currently ordered and in use. Restraint orders. This is very important. As the accreditation manager, I'm responsible for the surveys for accreditation. And University Medical Center is accredited under DNV. They come once a year. Restraints is always something that is high on their list. Anything that has to do with patient rights is highly looked at for our processes, make sure we're taking care of the patients correctly. So in 2015 for our survey, they noticed that there was an order, and we had made our policy that we had to have for the nonviolent restraints and for the violent a new order every 24 hours. Now, under the Texas law, the Texas physicians have 96 hours to sign orders. Therefore, you would have an order populate for the restraints every 24, but then the doctor wouldn't be signing them until pretty much 96 hours. And the surveyor had nursing informatics masters in this area, and she noticed that our system was populating the orders every day, not a physician. And this was a huge violation because it has to be a physician order. And so, therefore, we had to do a corrective action plan. And the longer you work here at University Medical Center, this is something that you will learn very quickly. It's always bettering our processes. We do not do everything perfectly, and we always strive to do things better. If they're good, we're going to make them better. And so, therefore, as our corrective action plan, we had to redo how we did our orders for restraints. And one of them was it has to be based upon the order of a physician. Also, we noticed that our time limit for getting a restraint order renewed was way too strict. So we'll be going over this in a little bit more detail. But an RN may initiate a restraint, especially if it's an emergency situation, to keep the patient or someone else safe, nonviolent or violent, and a physician is not available, you can go ahead and physically put on the restraints. However, a phone call must be made to the physician and obtain a verbal or telephone order immediately following the application of restraints. And this was taken to our physicians, our PI committee, which many physicians sit on, and we asked them the definition to them of immediately. And this is the same as a change in patient status. So if their patient has changed and all of a sudden are needing restraints, they want to know immediately. And this is not to exceed 30 minutes. So we run a report to make sure that the order is placed from the time the restraints are put on to the time the order is placed in the computer of 30 minutes. And then, of course, this is signed by the physician within 96 hours. There are no more PRN orders. In the past, if you've been a nurse that has practiced for many years, you will know that there used to be restraint trials. We'll take you out of them a little bit. If you do okay, then you can get out of them. But if we need them again, there's still an order for it. This is no longer allowed. If the restraints are removed because the patient was thought to be okay to get out of them, that is the discontinuation. It does not matter if it's 30 seconds later, if you put them back in restraints, this is a new order. And then if the restraint is used based on a significant change in the patient's condition, you need to notify the physician immediately. In the event of unanticipated or immediate danger, security or one or more trained RNs, they may initiate the use of restraints or seclusion before an order is obtained. However, once again, like we just discussed on the slide before, you need to notify the physician immediately. Now, if it is referring to violent restraints, the patient is aggressive, a physician must see the patient within 1 hour of initiating violent restraints. All the physicians have been educated on this. Of course, it never hurts to remind them if you're out on a department where a physician is not physically available, they are being called in, then it would be nice to remind them. But they must come in and see the patient. A lot of the violent restraints are put in the emergency center. It does help that the physicians are right there 24/7, so they do their assessment upon initiation of the restraints a lot of the time. So this normally is not a huge issue, but if you're in a department that the physician has to be called in, they must come and see him within 1 hour. Just to quickly go over, there's some time limits and renewal of orders. I've divided these up into the time limits of 18 years or older, 9 years of age to 17, and then under age 9. This is exactly how CMS categorizes them. And then, of course, we've categorized them into nonviolent and violent. A renewal for an order for nonviolent is 10 days, period, end of story, across the board, which is nice. It used to be 24 hours. And this is where it got us in trouble with the system ordering our restraints every 24 hours. And some people may be thinking that this is a very long time. However, you're thinking of medically restrained patients. A lot of these are ICUs for long extended periods of time. 10 days is actually the definition by Texas law of an extended use of restraints. Therefore, this is where our policy and procedure of 10 days came from. However, violent is very defined by UMC, but also CMS. Violent has to be renewed every 4 hours, 2 hours, and 1 hour. Patient monitoring and periodic assessment. I'm not going to go in this in great detail. This will all be on your task list as you're doing your assessments, and it will fire your assessments every 2 hours for nonviolent and every 15 minutes for violent restraints. So as soon as you put them on, you're going to have an initial assessment for each one of these. And then your task list will already have appeared, and for nonviolent, you will see the assessment every 2 hours. For violent, you will see it every 15 minutes. And every single assessment needs to be completed. And then once again, these are the periodic assessments that are looked at, PRN, so range of motion. These will also be on your task list. Just to define it a little bit better, restraint and seclusion. If these are used simultaneously for violent or self-destructive behavior, they need to be monitored by trained staff, which all of you will be trained, through continuous in-person observation or through both video and audio equipment that is in close proximity. So if a hospital does not have video and audio capabilities to be able to stay outside the room, then it is an in-person observation. This is limited, once again, to only the emergency center. And of course, then once again, you can always refer to PC 15 for suicide documentation requirements. Prolonged use of restraints, of course, for the nonviolent, once again, is 10 days. For 24 hours for the violent restraints. So I work in the Performance Improvement Department. You will notice PI, that it stands for Performance Improvement. To help stay in compliance with the 10 days, because after a while, you tend to forget that you're going to need a new order. It's just always been there every day. We have a person in our department, Karen Mathis, who looks at restraint reports every single day. A report fires stating, has a list of every patient in the hospital that has an order for restraints. If a patient is on day 9, She will contact the charge nurse or speak to the actual nurse to verify that the patient is still in restraints, and if that they're still needed, then to please contact the provider because a new order is required. This is very important for the fact that on day 10, this order will automatically stop with your task list, which has a very high risk of a patient still being in restraints if you forget to order this, or the physician, and the patient will still be in restraints without documentation, which could be a finding from DNV or CMS if they come in to do a survey. So it's very important if you get a phone call on day 9 to go ahead and contact the physician when they round, or go ahead and call them to go ahead and put in a new order. So when that order falls off on day 10, you will be covered, and it will still fire the task list. If they're still in use, an unusual occurrence report is made, and this is filled out by Karen Mathis, so this is not something that you as a staff nurse are going to have to keep up with. But we do an unusual occurrence report for the simple fact of tracking. We are mandated by CMS to keep data on restraints. How long? Are there any trends? Is there a certain day of the week or a certain shift that puts more restraints on than others? And to follow up on these type of things. So to help us keep better track of these, a report is filled out by Karen. And the same will occur for violent restraint use after 24 hours. So she has not made many phone calls at all about violent restraint use for 24 hours. But if that does occur and your patient is in them, you will receive a phone call from her regarding this also. Plan of care. Our plan of care here at University Medical Center is electronic, which is very nice, but it also can be very hard to remember that it needs to be updated. So a nursing care plan specific to restraints always fires when restraints are initiated. And so this helps you to just remember when they're applied, and then you're going to update them every 72 hours or restraints have been discontinued. So this is just another documentation that if anything changes, to update your nursing care plan. It does suggest it when restraints are ordered or they're put on and documented. So please go in, fill it out, and you will learn this also in your IT documentation class. Patient education and family involvement. This sounds very simple, but I think sometimes in all the hustle and bustle, we tend to forget that simply taking the time to explain to a family and to the patient exactly what is going on makes a huge difference. And it does make your life as a nurse a lot easier when people understand the reason why. I take it just as an example for my children. When I'm able to say the reason why I need them to do this certain thing, they are more willing to do what I ask versus because I said so, or this is what we're going to do. And they always ask why. And without an explanation, it makes it very difficult for them. This is the same when you have a patient and family in a hospital. This is a confusing time. It is a scary time. And so taking the time to educate them and reinforcing why they're in restraints, what this is used for. We're trying to keep your patient, your family members safe. And this is what, when they reach this point, they can come out of them. It just makes them feel at ease, and it will help the family maybe with your patient to explain or help them reach that goal faster for you. Discontinuation of restraints. This is required when the patient no longer displays the behavior that led to the initiation of restraints. So when you go in and you do your assessment, as you're done, so for nonviolent every 2 hours, if they've been in it for 4 and you go in and they no longer need it, then you need to document a discontinuation date and time. What this does is it gives us the exact how long we're using restraints. This is a data point that we focus on. Also, it stops the order and it stops the task list. So please remember to document your discontinuation of restraints. A trained staff, of course, may remove the restraints at the earliest possible time, regardless of the expiration of the order. And an RN is able to do this in the care plan. and the documentation. So please remember, and it's up there, it's highlighted, and then it's very nice because it reflects the data so much better, and then it will stop your task list. Reporting death to CMS. This is something the performance improvement is responsible for. However, the house supervisor monitors this also. So if a patient dies while in restraints and seclusion, we are required to look into it. If this patient is in 4-point restraints, pretty much they cannot move, and like bilateral wrist, bilateral legs, we will do an investigation. And if the death occurred within 24 hours after they've been removed out of the restraint or seclusion, also we will look at. If it shows that the patient looks like they died in the restraints and they were 4-point, we are required by CMS to report this to them. And so we have a very short time frame of when we have to report it. And then what CMS will do is they will look at our report and they will decide if they need to come in and do a follow-up survey. And we had one almost 2 years ago that the documentation, I have no doubt that the nurse went in and checked on this patient frequently. It was a non-violent, but they did document that they went in and found the patient unresponsive and coded, and the patient did not make it. So therefore, this event had to be reported to CMS. And no follow-up was done by CMS, no harm. It was an event that we looked at. We did re-education, so it was fine. But this is something that we have to definitely report to CMS by the next business day. Basically, the biggest thing with restraints for findings from surveyors from DMV, or if CMS was to come in, is just monitor your patients, which I believe everyone does a good job at, but give yourself credit for the hard work that you do, and just go in and document your assessments, document all of the things that you have done on this patient. We know that all of our nurses do such a great job with caring for our patients. However, when you go back and look in the chart, sometimes it's very hard to find the good care that we provide. So simply just taking the time to go in, document your assessment, document each time, and anything extra, nurses' notes are always great. Just tell the story of how well you took care of this patient. The other thing to discuss when we're talking about restraints is the forensic restraints. And this is something that you do not necessarily have to take care of from the nursing side, especially if it's law enforcement, the handcuffs. However, if there is a situation where the handcuffs become medically unnecessary for a certain reason, the physician has to place an order for forensic restraints, bilateral soft wrist restraints, or if they're all 4-point restraints with the soft. This order is required every single day that the patient is not in their forensic handcuffs. This is required by the warden for the prisons. This is also something to keep the prisons from being responsible for if anything happens. Then they will note that the patient or the prisoner was not in their forensic restraints. Therefore, it would be, why was the prisoner still in soft restraints? They need verification that the physician is still wanting these. You do not have to document an assessment under restraints, nonviolent or violent. This is not every 2-hour assessment. However, of course, they would still be part of your skincare assessment, making sure they're not getting any pressure ulcers. But a forensic restraint will only be in the care of the nurse if they go forensic restraint, soft, for medical use, and you're monitoring for pressure ulcers. But this is not a real, true, nonviolent or violent restraint order. So that sometimes is the gray. Sometimes there is the use that they do need medical restraints so that they're not picking at something, or that they're not going to pull out their ET tube even though they have handcuffs, then you could have the possibility that you need to order nonviolent restraints, or if they are violent. So there is the time that you will have that order put under patients or prisoners, but it's very rare, and you will have the forensic order, but this is not required by the nurse to care for these type of restraints. This is the conclusion of our restraint PowerPoint and discussion. Please, if you ever have any questions, you can always ask your educator. You can email me, carrie.jennings@umchealthsystem.com. Also, during your demonstration for restraints, you can always ask questions. Nursing education knows exactly where to find me. So welcome to UMC. Thank you so much for your time here. I hope you learned a little bit of something and it was a little more clear on restraints. Thank you.
Oh, maybe if I resume it and then